Hello, and welcome to today's Center for Healthcare Strategies webinar on trauma-informed screening, assessment, and treatment for children and youth in child welfare, part of the Psychotropic Medication Use Among Children in Foster Care Technical Assistance webinar series. To eliminate background noise, phone lines are being muted for today's presentation. Questions and answers will be held after Connecticut's presentation and again after Texas's presentation. Questions may be submitted using the feature displayed on your screen. If you experience technical difficulties today, you may dial 1-866-229-3239 for technical assistance, or click the question mark icon located in the floating toolbar at the top of your computer screen. Today's event will be recorded and the slides will be sent to participants after the webinar. At the completion of the webinar, we ask that you fill out a very brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you will complete the survey. I will now turn the webinar over to Kamala Allen, Director of Child Health Quality at the Center for Healthcare Strategies.
Thank you, Nancy. Hello, everyone. I want to thank you for registering for today's webinar, the fourth in our Technical Assistance webinar series. We are providing this technical assistance with support from the Annie E. Casey Foundation, who's supporting the work of our six-state, multi-state collaborative, including the states of Illinois, Oregon, New Jersey, New York, Vermont, and Rhode Island. This is supplemented by support from SAMHSA's Child, Adolescent, and Family Branch under the direction of Dr. Gary Blau through cooperative agreement with ACS. The focus of our technical assistance series is on establishing a foundational context around the topical area and then delving into implementation, sustainability, and policy implications. So we hope that you have enjoyed previous webinars in this series if you've been able to join us. If you haven't, please check the CHCS website for the previous webinars. And as was mentioned, this one will be posted as well. Next slide. Oh, you've already moved to the next slide, okay. So the slide, I need to go back one slide, please. You could go back one slide, thank you. So just to provide a little bit of context for today's presentation. We know that children in foster care represent a high-need, high-cost population. We've recently completed a national study of Medicaid claims data, and within that, we conducted two special analyses related to this population, one looking at the behavioral health needs of children in foster care in general, and one looking specifically at psychotropic medication use. We found that children in foster care represented 3% of the Medicaid population in the study year, 15% of children on Medicaid who receive behavioral health services, and nearly 30% of total Medicaid expenditures for both physical and behavioral health services in Medicaid. While we would certainly expect that a subset of children in foster care have higher rates of behavioral health service needs, we wouldn't necessarily expect that it's 5 times the representation of the population and nearly 10 times that in dollars. In any case, this should be cause for attention for policymakers and service providers, both in foster care, in the child welfare system, and in other child serving systems such as Medicaid, Children's Behavioral Health, and Juvenile Justice. While the Child Welfare Agency is acting as a parent for these children, as I suggested, these other systems certainly have a responsibility, and in many cases have programs in place that can benefit this population of children. Recent legislation in terms of fostering connections requires a collaborative approach specifically between child welfare and Medicaid to meeting the behavioral health needs and developing a service plan for children in foster care. And we see this as an opportunity to leverage that joint responsibility for this population. We know that children in foster care have experienced abuse, neglect, or both. That may result in trauma. And while our work here at CHCS is to really support state systems to provide the most appropriate and high-quality care to vulnerable populations with an end goal of improving outcomes, for our child health quality team, children in foster care are definitely a high priority. They're likely to have been exposed to trauma, and determining the most appropriate care is probably going to require that some screening be conducted to determine whether trauma or behavioral health needs are really the drivers for the behaviors or the symptomatology that we're seeing. And so as our first speaker will describe, there are high rates of co-occurring trauma and mental health needs among this population. And so the work that we're doing through our Quality Improvement Collaborative and specifically on the webinar today are to provide some examples of how states are implementing trauma-informed systems and how the ACF at a federal level is supporting those efforts. Next slide, please. So what do we really mean? I'm sorry, this is actually not the right slide. Should be a slide entitled, what do we mean by trauma-informed? Okay, we may have the wrong slide back up, and I apologize. I'm going to try to not read to you because I don't like to read, but I want everyone to have the same sense of what we mean by trauma-informed, since that's the context for today's presentation. The definition that was developed by the National Child Traumatic Stress Network's Trauma-Informed Service Systems Working Group provides context for our discussion today. And since we don't have that slide, I will highlight certain aspects of this definition. That work group proposed a definition that describes trauma-informed systems as those in which all parties involved recognize and respond to the impact of traumatic stress on those who have contact with the system, including children, caregivers, and service providers. Programs and agencies within such a system infuse and sustain trauma, awareness, knowledge, and skills into their organizational cultures, practices, and policies. They also act in collaboration with all of those who are involved with the child using the best available science to facilitate and support the recovery and resiliency of the child and family. So when we are thinking about trauma-informed care, we're thinking about recognizing and responding to trauma, sustaining awareness, knowledge, and skills, and incorporating that into organizational culture, practice, and policies to support families in recovery and resiliency using evidence-based, evidence-informed approaches. So what does that look like? The same work group has proposed that a trauma-informed system does several things to recognize and respond to children who have experienced trauma. Number one, they routinely screen for trauma exposure and related systems. You can move to the next slide, please. And then we'll be in sync. Here we go. Thank you. They use culturally appropriate and evidence-based assessment and treatment. They make resources available that will bring a benefit to the child and family to support the providers. They engage in efforts to strengthen resilience and protective factors, recognizing that families involved having experienced trauma do also have some strengths, and so how do we support them in the areas that we can leverage to increase their resilience and recovery. We want to acknowledge the fact that oftentimes parents and caregivers have also experienced trauma and that has an effect on the family system in which the child is being raised. They emphasize the continuity of care and collaboration across child service systems, which I alluded to earlier. And finally, they maintain an environment of care, recognizing that staff who are supporting children and families that have experienced trauma may be also subject to secondary trauma stress. So with that context and with that backdrop, we're very excited about the panel of speakers we have for today. Next slide, please. We have Dr. Joy Spinning from the Administration for Children and Families, who's going to provide an overview of trauma-informed work and grants that ACF has made to support states in these efforts. And we're going to hear from two states, Connecticut and Texas, who have undertaken this work and really have, I think, great stories to tell. So without further ado, I'm going to move very quickly to introduce Dr. Spinning. Joy Spinning is a federal project officer at the Children's Bureau, where she oversees 3 demonstration grant clusters focused on developing innovative ways to ensure that children in child welfare with mental health and trauma treatment needs are identified early, monitored frequently, and have access to timely and effective treatment services. She joined the Children's Bureau after working for nearly 20 years in Illinois child welfare system, and for 10 years she was part of a specialized team at the University of Illinois Chicago Department of Psychiatry that consulted with the Illinois Department of Child and Family Services and treatment providers to improve safety and the quality of mental health services. Before joining the Children's Bureau, Dr. Spinning provided program and organizational consultation to residential treatment providers, and she holds a PhD in clinical psychology from the University of Vermont with a postdoc fellowship at the University of Illinois Champaign-Urbana. So with that, I'm going to turn it over to Dr. Finning.
Thanks, Kamala. I would have written that better if I'd known you were going to read it. Sorry about that. Thank you for having me. It's really great to connect with some of the folks who are on the phone, who I'm assuming some of you were at the Psychotropic Summit that we sponsored last summer, 2012, not 2013. And I'm excited to have a chance to hear more about the good work being done by our grantee in Connecticut and to hear about the work going on in Texas as well. Children's Bureau is now launching a third round of what we affectionately called our trauma grants. So we're now launching, in the process of launching Trauma3. I had been asked in this brief time I have with you to provide an overview of ACF's focus on trauma-informed approaches and kind of what led us there, and to talk a bit about the grants that we've made to date. I was asked also to provide any data that we might have on outcomes. Of course, it's pretty early days, but I will share some impressions about the work that's been going on so far. Next slide. So as you all know, children involved in child welfare have disproportionately higher rates of mental health and behavioral health needs, and they're also prescribed higher rates psychotropic medication than those children in the general population. Kamala gave some great citations on that. This particular slide is drill down into some Medicaid data. I know we did that in 2010, but I'm not sure what years the data are from. It could be 2010. This slide shows rates of mental health prescriptions, mental health services, and then the last bar in each of these groupings is the total use of mental health service. That's the combination of any kind of mental health services, whether it's medication or other types. And it's broken down by age groups. So the first grouping on the left are the very young children, and you can see, as you'd expect, that psychotropic medication use is much lower there, although probably higher than many of us are comfortable with. You'll also, well, moving on to the next age group, you'll see the increase in psychotropic med use and slight increases, again, for kids who are in adolescence. One interesting thing about this slide is that it shows that in most cases, in many cases, mental health services are prescribed in conjunction with psychotropic medication. So most kids in child welfare seem to be receiving both modes of treatment. By the way, these slides were borrowed many of them were borrowed from Brian Samuels and Kate Steepleton, who were at ACYF and are no longer with ACYF. So I thank them for some of these slides. Next slide. So studies have shown that between 50 and 80% of kids in out-of-home care have clinically significant behavioral and emotional functioning needs, which is huge, as Kamala pointed out. This particular slide shows NSCA-2 data related to service use in relation to different types of identified problems. I think what's really interesting about this slide is that there are not great differences between the rates of need in services between those kids who are in home and those who are out of home. So a lot of us focus on the results of bringing kids into care, and an assumption can be made that there are differences, great differences between those populations of kids who are in contact with child welfare and out of home versus those who are in home, and that doesn't seem to be the case based on these NSCA data. Well, then I just lost my cursor. Curses. Next slide. So why a trauma focus? While we don't know that exposure to adverse events, including trauma, are the sole are solely responsible for increased rates of mental health and behavioral problems in child welfare populations. We do know that adverse childhood experiences, including physical and emotional trauma, can have potentially devastating effects on physical, cognitive, social, and emotional development. And we also know that those adverse child experiences in childhood can have a multitude of negative consequences in the long run, even into adulthood. And so that's mostly from the ACEs study that I'm sure you all are familiar with. It's a great piece of work, and I hope we continue to focus on that. We also know that the more adversity faced in childhood, the greater impact. In one study, we found that nearly 80% of abused children experience at least one mental health challenge by the time they're 21. So we know that, well, we don't know that there's a direct causative effect between childhood trauma and these high rates of mental health and behavioral health issues. We do know there's a strong connection. Kids in child welfare, as you all know, have been exposed to many traumatic events, persistent poverty and neglect, separation loss from primary caregivers, disruptions in family and friends, school, physical and sexual, emotional abuse itself. But our kids are also more likely to have been exposed to additional adverse circumstances than other kids in the general population. So they're more likely to also have been exposed to domestic violence, parental substance abuse, exposure to trauma in the community. So high rates of trauma in our population. This particular slide comes from an article by Jean Griffin from Illinois. So I guess we got Illinois folks on the phone, maybe Jean. And the point of this slide is that in an examination of CANS data from Illinois, a great amount of overlap was found between those symptoms and function deficits that can be attributed to trauma and those that are attributed to mental illness. So given that overlap, and here's some examples, that same symptoms that you might diagnose as attention deficit disorder, restlessness, hyperactivity, disorganization, difficult sleeping, hypervigilance, et cetera, could easily also be attributable to trauma. So the punchline in that piece of work, which I think is a great piece of work, is that therefore, why not assess and treat trauma first, where trauma is, where the assessment for trauma finds that trauma treatment is appropriate. Next slide. So, most of you know that ACYF has been involved in a lot of activities related to psychotropic medication, and we may have crossed paths in some of that work. The interagency work that we've been doing in conjunction with CMS has resulted in state director letters and information bulletins that have been produced by CMS, helping to help states find ways to finance services that are effective for kids who've been exposed to trauma. We have ourselves released an information memorandum on psychotropic med use. We did a bunch of webinars a couple of years ago on psychotropic med use in foster care, and issued a well-being memorandum, also related. And then finally our summit, and a great guide developed by Linda Mitchell and others at Children's Bureau for Youth. If you're not familiar with that guide, take a look at it on our childwelfare.gov website. But the unifying element to all of this work, the foundation of all of this work, is the recognition that that identifying and responding to trauma can reduce our reliance on psychotropic medication. So that's very foundational. Another key piece to all this work, and it's just shown in the process with which we've engaged in it, is that cross-system collaboration is needed, and we've tried to engage in that kind of collaboration at the federal level, and are happy to see you guys also doing that at the state level in this process. Next slide. That same connection between the need to assess for and treat mental health issues, especially those associated with trauma, and to provide oversight over psychotropic meds. That linkage is also represented in the reauthorization of promoting safe and stable families, which I know you guys are familiar with because it's given us the opportunity to engage in conversations with the states on how you might develop your state plans that you provide in child welfare to show how you're going to accomplish those goals. So it's one way in addition to our discretionary grants that we're able to make this connection. With regard to the discretionary grants, there are now three cohorts. And next slide. These grants are funded under adoption opportunities, which is legislation that's promoting increased rates of adoption and adoption stability. So ultimately, the goal of all three grants, while we call them Trauma1, Trauma2, and Trauma3, is that our kids reach permanency and especially that they find permanent homes adoption where it's appropriate, and that if they're placed in adoption, adoptive families, that those homes are stable. So at Trauma1, we have a representative from that group on the call, so I'll let them talk more about their project. It's a set of 5 grants: state of Massachusetts, the state of North Carolina, Connecticut, the University of Montana, and University of Colorado. I'll talk a little bit more about what each of these grants does in a little bit, so I'm going to kind of combine that. Next slide. Difficulties with mousing here. Trauma2, as we call it, the initiative to improve access to needs-driven, evidence-based, evidence-informed mental health and behavioral health services and child welfare. That's a mouthful. We have 9 grantees, and you can read from that list there. The next group, next slide, just now being launched. So our Trauma3 grantees are University of Kansas Center for Research, University of Louisville Research Foundation, New Hampshire, which also Dartmouth College is one of our Trauma2 grantees. So this is, 2 different aspects of work with the same same related goals. A grant in Tennessee, Harmony Family Center, Vermont, and Rhode Island. So the next slide provides kind of a high-level synthesis of what these grants are about. So moving from the left to the right, our approach is that we want to achieve, our goal is to achieve better outcomes for kids. So permanency, obviously, but more expanding that, and that was largely the vision of Brian Samuels while he was at ACYF, is increasing well-being outcomes in our child welfare populations. So moving from left to right, the first step in the process is being able to identify those kids very early who have mental health, behavioral health needs, and specifically trauma-related needs, and making sure that those kids are, where there are indications of need, are referred for a clinical assessment that's also trauma-informed so that we can determine what the best possible treatment is. And then at the bottom, we're also advocating for ongoing measurements of well-being. So these are monitoring outcomes over time. And so you can see the arrow along the bottom, which represents that these are repeated across time. So we're really asking systems in general to adopt processes for tracking how kids are doing using psychometrically sound, reliable, valid, sensitive, specific measures that are able to tell whether kids are doing well or not in response to the services that they're receiving. And of course, those things are interrelated because if we track an individual child's outcomes, you may then assess further and determine that additional treatments are needed. So another key piece of these grants are that we're asking for case planning processes that are data-driven. So based on those measurements, those psychometrically sound measures, we're asking states to develop practices that use that information to determine what kind of services children and their families need, and to find ways to scale up those treatments that are that work. So in those cases, evidence-based treatments that fit the needs of not only individual children, but that match the needs of the overall child welfare population as you're measuring it using your ongoing progress monitoring. And the ultimate outcome would be then increased safety, permanency, and well-being. Next slide. So the goal, again, is creating systems that are flexible, that align with measured needs, and that give systems the information they need to scale up the things that work and invest in what works, and scale down, stop investing in those things that don't work. And next slide. So where does Trauma-Informed Practice come in? I was asked to talk about ACF's Trauma-Informed grants, and it's kind of interesting because really we are asking for a trauma-informed approach, but we're not asking specifically to install trauma-informed practice. That said, almost universally, all of our grantees have said, in order to do the things that were in that slide about achieving better outcomes, in order to do those things, we need to have in place a workforce that is trauma-informed, that knows how to recognize and respond to the impact of trauma, that has the skills, knowledge, awareness necessary to perform their tasks, that we need to not only address the trauma needs of children and their caregivers, but also providers in the system. So in a way, in these grants, the way I see it is the trauma-informed practice piece has become an important mediator to establishing the system, putting the systems in place that we want to put in place. So they become almost, in implementation science terms, they become the drivers to make sure that these steps can be taken effectively by states. Next slide. So what have we learned? I feel very honored to be in a front row seat watching some of the great thinkers and experts, people actually doing this work and the heavy lifting, and I get to learn from those folks. So we're just now beginning to get some data back from the Trauma1 grantees, and you're going to hear Connecticut talk a little bit about what they're learning. But one thing I've gotten to learn is that, first of all, measure selection is not easy. We'd like to think that there are compendia out there where you can just go out there and pick one. We're learning that it's very important that states not only assess the attributes of the measures that they're looking at for screening and assessment in terms of whether they're reliable and valid and so forth, but also to look at the fit with their particular system, and whether the system's ready and has the capacity to implement those screens and assessments. So no two systems are alike, and so in all of these little experiments that we've got going, so between the 5 first-year grantees and then the 9 in the second round, different approaches are being taken universally. People have chosen different screens, different assessments, different approaches to doing screening and assessment. So it's fascinating. It's really about the implementation because it's the result of these grantees having the opportunity to dig deep into their systems to assess what's unique, what's needed, what's feasible, what are the capacities, what are the strengths, what are the weaknesses, where are the barriers. That's allowed people to kind of make their own decisions about how these projects will roll out. So they are, at heart, these grants are implementation grants. And so after 5 years of each of these grants, we're hoping that one of the messages we can disseminate to the field is, hey, what does it take to implement these things in a system, and how is, why do different why have different grantees taking different approaches? Another lesson is that there's no straight course forward. Constant course corrections have been required. It's required people to have amazing amounts of flexibility and patience and good humor. The grantees that are doing the best have just developed some amazing communication and collaboration foundations among and across agencies. So anyway, that's just preliminary, and it's largely processed. So we hope to have more data to share with you as time goes by. Thank you.
Thank you so much, Joyce. That was very informative, and I think provides a very nice context for our first state presentation from your Connecticut grantee. We actually have 3 colleagues presenting for Connecticut this afternoon. Just in the interest of time, we did send out the bios, but very briefly, I do want you to know who you're listening to. So we have Marilyn Cloud, who is a clinical manager at the Connecticut Department of Children and Families. Her career spans more than 40 years working within both public child welfare agencies and community-based health clinics. She served as a state project coordinator for Connecticut's trauma-focused CBT, or Cognitive Behavioral Therapy, Learning Collaborative since 1997, and she currently serves as the co-principal investigator for the Connecticut Collaborative on Effective Practices for Trauma, or CONCEPT grant that Joyce mentioned. Secondly, we have Christian Connell, who is an associate professor in the Department of Psychiatry at the Yale School of Medicine. He's also director of child development and epidemiological research at the Consultation Center at Yale University. He has a particular focus on outcomes for children and families involved with child welfare and the children's behavioral health system, and he has over 15 years of experience providing evaluation research and consultation services to child welfare and other community-based organizations. Finally, we have Jason Liang, who is Associate Director of the Connecticut Center for Effective Practice at the Child Health and Development Institute of Connecticut. He is a licensed clinical psychologist who holds an appointment as an assistant clinical professor in psychiatry at the University of Connecticut Health Center Child Trauma Clinic. He's worked across behavioral health, child welfare, law enforcement, medical, and juvenile justice systems to develop a more trauma-informed system of care and improve the quality of care provided to children. So with that, I'm going to turn it to our colleagues in Connecticut.
Thank you, Kamala. Also, thanks to the Center for Healthcare Strategies for inviting the state of Connecticut to participate. First, I'll provide some brief background information to better understand the overall context in which we are conducting our trauma-informed care work. The Connecticut Department of Children and Families is a comprehensive children's service agency. We are statutorily mandated to provide child welfare, juvenile justice, substance abuse, behavioral health, and prevention services to all children, youth, and families in the state of Connecticut. So we are a complex, multifaceted system with many challenges and demands. It was not until about 6 or 7 years ago that the department, in partnership with a group of diverse stakeholders, began to focus more intensely on building a better statewide trauma-informed system. At that time, there was very little awareness and knowledge of childhood trauma, and particularly its impact on children and families by our workforce. And there were almost no trauma-specific assessments and treatments available within the community. We have been engaged in a federal lawsuit known as 1S since 1989. This lawsuit was filed on behalf of foster children whose physical and behavioral health needs were not met, and we are still focused on meeting those needs. So we began in the early 1990s to look at ways that on the behavioral health side we could bring more effective quality of clinical care to children and youth with behavioral health needs. We began to introduce and disseminate across the state some evidence-based practices that were primarily focused on in-home care. It really was not until 2007 that a formal dialogue began, a formal statewide dialogue. A trauma summit was convened. It was attended by treatment developers, researchers, state reps, providers, families, and others to begin a dialogue and some initial planning. We began to look at what existed in terms of our current array of behavioral health services, where were the gaps, what needed to be done, and from there we began to disseminate trauma-focused cognitive behavioral therapy within community clinics. This occurred over a span of 3 or 4 years and is still ongoing. We also had a change in our DCF leadership in 2011. With this change came a new type of child welfare practice model known as Strengthening Families, and we consider trauma-informed care as one essential core component of that model, not a distinct standalone piece of work, that may only be short-term. Our work has also been advanced by changes in federal policies and recent laws. Certainly, we've been doing more work with our staff around paying equal attention to psychological safety of children in addition to physical safety. We've also been doing work around better understanding how we can achieve permanency and continuity of care for children by looking at their trauma history exposure, trying to get them the right treatment, so hopefully there will be fewer disruptions, less use of medication. We've certainly been more focused on the emotional social well-being, and with the recent change in the CFS Improvement and Innovation Act that Joyce mentioned that requires states to address in their state plans how they will treat children who have been traumatized due to maltreatment and then removed from their home. Then in 2011, we did receive one of ACF's Trauma2 grants, which has further advanced our work. And unfortunately, last December 14th, we had the horrific school shooting at Newtown. This resulted in an intense set of dialogues across the state with citizens, with our legislative leadership. And as a result of that, this past legislative session, we were awarded more funds for specifically trauma-specific treatments within our behavioral health system. We also are required now by statute to look at the entire array of service system again and determine how to strengthen it and better meet the needs of traumatized children. Next slide. So as I mentioned, we were fortunate to receive this grant in the fall of 2011. Our grant is known as the Connecticut Collaborative on Effective Practices for Trauma. It's a $3.2 million 5-year grant. The overall purpose is to create a more trauma-informed, trauma-focused child welfare service delivery system. We identified 3 project aims to accomplish this. First, we are working to increase our own workforce capacity to identify traumatized children and to respond more effectively by referring them to appropriate assessments and care. The second aim is to enhance access to evidence-based trauma-informed interventions in the community. And our third goal is to provide more education and support to our workforce to reduce and prevent secondary traumatic stress. The third goal was not part of our original grant, but was added based on the feedback from our workforce. We heard loud and clear how difficult the work is and how staff need to really also continue to focus on their own health and well-being in order to be at peak service for the traumatized children and their families. These project aims are carried out through 5 major activities. The first is increasing the knowledge and skills of our own workforce, and part of this also is transforming our child welfare practice so that we include trauma-informed care in every aspect of our work, from assessment, goal setting, case planning, monitoring, and our termination phase of work. The second area of activity is around developing a universal trauma screening tool and process so that at the earliest point of contact, we will identify trauma history exposure for children, those who already may have child traumatic stress symptoms, and make sure they're connected to community-based trauma-specific treatment providers. In order to connect them with effective providers, we need to also further disseminate trauma-focused cognitive behavioral therapy across the state, and we are also going to disseminate in 2 years of this grant an acute trauma treatment known as child and family traumatic stress intervention. And last but not least, we will conduct evaluation activities of the entire project, and Dr. Connell is going to speak about that. Next slide. So beginning this work, we focused as well on how do we embed it and institutionalize it within our existing child welfare structure. We began thinking about sustainability on day one because we recognize the critical importance of this work if children are to heal from trauma and become healthy. So these are some of the ways listed on this slide that we are working to change child welfare practice. Everything we do, we hope to embed within our child welfare structure and our operations. I mentioned briefly our Strengthening Families practice model. trauma-informed care under our commissioner is one of the key principles of child welfare care. We have written a trauma-informed practice guide and policy that pulls all of our work together in a more trauma-informed way. We will continue to review our policies and practices, any relevant child welfare policies and practices. When we began this review, we did a word search to see how many times trauma-informed care appeared in these various policies and practices, and the answer was 0. So we've been doing a lot of work in that area. We also have identified trauma champions in each of our area offices, and we have worker wellness and support teams in each of these offices. And their goal is to continuously promote the trauma-informed agenda. They serve as ambassadors. The trauma champions are charged with conducting at least one activity a month, that is either organizing it or conducting one activity a month that is educational, case-specific learning, maybe having an expert come in to talk about the implications of trauma on children and their families, maybe having a director of a child welfare, of a mental health clinic come in and talk about the trauma-specific assessments and treatments that they deliver, and it's been working very well. We also have been focused on workforce development. As Joyce mentioned, we have to start with making sure that our workforce is armed with knowledge about what childhood trauma is, how it affects all domains of a child's life, and how if it's not identified early and treated early, these children may suffer with lifelong physical health and mental health devastating consequences. So we have adopted the National Child Traumatic Stress Network's Child Welfare Trauma Toolkit training. It's a 2-day training. We began this training in early spring, and we are not only training managers and administrators, but also our frontline staff. It's mandatory. We've done some cross-training with our local community providers, including those TFCBT teams located at our outpatient clinics. And as I mentioned earlier, we're also focused on practice transformation. It's not only about screening and referring, it's working with staff about understanding what do they do with the information they gain from those trauma screens. How do they use this information when they set case plan goals, when they determine what services need to be delivered, when they evaluate their case. Next slide. And although the use of psychotropic meds is not one of our project aims under the concept grant, we clearly know how important the issue of psychotropic medication usage is. It's of critical importance, and we anticipate there will be implications in this arena based on our trauma-informed care approach. We work very closely with our chief psychiatrist, who heads up a centralized medication unit within our department. This unit is staffed not only by our chief psychiatrist, but 2 APRNs as well as a trauma consultant. These colleagues review all committed children, and we have approximately 3,000, of whom 24% are receiving some type of psychotropic medication. Anytime a child is requested to receive psychotropic meds, the case is reviewed by this team. This team follows the child, their diagnosis. They know whether or not they're referred for trauma treatment or work with the local regional staff to get children referred to appropriate trauma-specific treatments. And basically this slide just shows that not only have we, through a number of concentrated targeted efforts, reduced the number of children in our care in the past 3 years, but the use of psychotropic medications has also gone down. Next slide. This slide is the beginning look at, what happens to the children who are in our trauma-focused cognitive behavior therapy learning collaborative. This slide represents 260 children and youth who receive trauma-specific assessments by trained TFCBT clinicians at outpatient clinics. And you'll see the smaller circle on the left. Now, this was at baseline or at the time of intake. 3/4 of these children were not on psychotropic meds, but 25% of them in this community sample were. 15% were receiving one medication, 8% were receiving 2 medications, and 2% receiving 3 types of medication. This is not just foster children. This is community profile, children in the community, which includes DCF involved and non-DCF involved. So what this says is that the use of psychotropic meds is high in the community as well. Of course, these children were assessed. They were referred because of their trauma exposure history and perhaps current trauma symptoms for a trauma-specific assessment. And the larger circle on the right just shows of those children who were taking psychotropic meds, what type of meds. Next, my colleague, Dr. Liang, is going to talk about Connecticut's efforts to disseminate TF-CBT within community settings, and secondly, to develop a trauma screening tool and process within our child welfare system. So I'll turn it over to Dr. Liang.
Okay. Hi, everybody, and thanks, Marilyn and Kamala. I'm going to talk about our work disseminating TF-CBT briefly and then more about trauma screening. And as Marilyn mentioned, in Connecticut, we began disseminating TF-CBT back in 2007. And you saw from Kamala's presentation earlier that a trauma-informed system of care, one of the components is the availability of evidence-based treatments for children suffering from trauma. And this was really the initial effort back in 2007. We began this by holding learning collaboratives based on the Institute for Healthcare Improvement's Breakthrough Series collaborative model that the National Child Traumatic Stress Network and a number of other states have been using as well. And through this year, we've now trained 28 clinics and more than 500 clinic providers in TF-CBT through the learning collaboratives and some standalone trainings that we also hold. Part of the process of this has been to realize that training and implementation is not enough, that there needs to be some infrastructure and support for sustaining the evidence-based treatments. And so DCF has continuously funded some ongoing support for these agencies that includes ongoing training opportunities, performance improvement planning, quality improvement, and some performance incentives for the providers that are meeting certain benchmarks for TF-CBT. You can see that we've served now close to 3,000 children, and this includes those who, 2,900 children who are received TF-CBT, and they've also received clinical assessments that are trauma-focused at the start of treatment and during treatment as well, every 3 months. About a third of those have been involved with the child welfare system at the initial time of treatment. And one of our big lessons learned from this initial work was that we actually didn't do a very good job of including DCF staff and child welfare workers specifically in the implementation. This was done in community settings. And since we were awarded the ACF grant in 2011, our focus has really shifted to disseminate TF-CBT in collaboration with child welfare staff. And so we now include child welfare staff in all of our learning collaboratives as partners with the behavioral health providers. Next slide, please. So I'm going to talk a little bit about the trauma screening work that we've done in Connecticut, and I have to say that we're still kind of writing this book, and we have not gotten to the end of our process yet. But we have learned, I think, quite a few things along the way. And of course, you know, as Kamala mentioned earlier, trauma screening and identification of kids is also an essential part of the trauma-informed system of care. And I think it's especially important because we know that avoidance is really one of the hallmarks of trauma, and without being asked some of the questions specifically about trauma exposure and symptoms, many children and parents don't volunteer that information. They don't volunteer it unless they're asked. And so our goals with trauma screening were really to inform child welfare practice, to help workers think more about the work they do from a trauma perspective, and also early identification of children who may be victims of trauma, to identify those kids before problems become more severe or before they turn into behavioral problems that are going to cause placement disruption or other significant problems, the use of more psychotropic meds, by intervening early and connecting them with evidence-based trauma-focused treatment assessments. And we also wanted to integrate trauma-focused treatment into the case plans that workers are using, so that it's not just seen as a separate screening process, but it's really an integral part of their work. And I think one of the significant components of that has been that historically there's sometimes a perception that all counseling or therapy is created equal, and therapy is often one of many, many checkboxes that a worker has to address in a case plan. And so we're working to increase our knowledge about different types of therapy, evidence-based treatments, and really matching kids who are in need of evidence-based trauma-focused treatment to that type of therapy. Next slide, please. When we started the grant in 2011, the first thing we did was what we called a roadshow, where we went out to all of the area offices, met with virtually all of the staff in the state through their all-staff meetings, and talked to them about the grant and about trauma screening specifically to get their input on how it would work and what we needed to consider. And through that process, we put together a smaller work group comprised of a number of field staff and supervisors and other folks that have worked on the trauma screening process and approach for the past couple of years. And the first thing that we heard was that there is a tremendous amount of interest in trauma. This is something that child welfare staff could really rally around, and they live it and deal with it every day. But many of them did not have much training in trauma-focused services, and actually very few had knowledge about the evidence-based trauma-focused treatments that were available in their communities, like TFCBT. They also told us that they wanted it integrated as much as possible with everything that they do and not to be seen as a separate tool or a separate process. It had to be simple and as short as possible. Interestingly, a number of staff said that, if you give us some tools and say, do this when you think it would be indicated, they didn't think that it would be done very much. So they encouraged it to be mandatory when it made sense. And we also did experience some avoidance from staff, similar to what we experienced with clinicians that we train in treatment. And many folks, when talking about trauma, there's sometimes a sense that, what's going to happen if I ask families and children these questions about trauma? Am I going to distress them? Am I going to get them too upset? Am I going to do harm by asking these questions? Know that that's not the case, but sometimes that takes quite a bit of work to get over that hump. And then, as Marilyn said, we did hear a lot about secondary traumatic stress and the needs of the workforce. Next slide. As we put all this together with our trauma screening work group and began to think about an implementation plan, we became clear that there are so many linkages to trauma screening with other programs and systems, and both within and outside of DCF. And so specifically with the community treatment providers of TFCBT, how those kids would get referred, and how the information would be exchanged, how it would be fed back to DCF workers, and all of the different systems within DCF, including the training academy and the quality assurance. Once screening is implemented, how is it going to be reviewed to make sure that it's being done appropriately and that kids are getting referred as needed. Marilyn talked about the policy, but many of the different programs within the department had different sets of processes and screening tools and assessments, and so we were trying to look for something we could embed screening in that would be universal, but that was quite a challenge. Next slide. So where we are currently in Connecticut is that we have, through this work group and a number of pilots, have developed a brief custom screening tool, in part because we weren't able to find something else that was short enough that met all of the other needs. And this tool is administered face-to-face as a brief interview with a child who's 7 and older and a caregiver separately. And the worker would enter it into the SACWIS system along with everything else that they're entering. And the system would generate an automatic recommendation for whether further assessment was needed or a referral to a community-based provider with a list of local providers of evidence-based treatments. That behavioral health referral would also be generated through the data entered that could be handed off to that provider. And the system would also pre-populate the trauma screening results into the CPS case plan so that the worker was reminded to address those with the family and at the reviews. We also plan to require screening every 6 months because we know that for many children, especially for children in the child welfare system, may be exposed to traumas in an ongoing way, and a one-time screening is probably not going to capture, going to miss many kids. And then the trauma passport was really the idea that if this is embedded in the SACWIS system, it would be available to any worker who has access to the child's case, regardless of where they are in the state or in the system, so that they could get a history of trauma screening if a child was moved or went into one of the facilities. Next slide, please. We've done several pilots of the trauma screening tool that I mentioned, and in general, these have been helpful because they've engaged many of the frontline staff in actually using the tool, overcoming some of that avoidance and concern about asking these questions directly. And one of the things that resulted was that we were not going to require it at intake, which is investigations here in Connecticut, because really because of many of the intakes were done in one shot with very little time for the worker to do much else, and then were closed because there was no substantiation. In the most recent pilot we've done in our learning collaborative with TFCBT providers, we did ask the DCF, the child welfare staff who screened, about their experience using the tool, and we found that they learned quite a bit of new information about families that they've been working with often for quite a while, both about trauma history and trauma reactions, and the majority also said that it actually helped inform their casework and case planning as well. Next slide. Where we are right now is that in this process of developing a trauma screening and getting it into the SACWIS system, the state made it, or the department made a decision that it had such an antiquated SACWIS system that the whole thing needed to be redesigned. So right now they're in the beginning process of redesigning the SACWIS system to bring it up to speed with current standards, and so we're going to be working with them to integrate integrate trauma screening into whatever this new system looks like. We're continuing to pilot in our current learning collaboratives with the goal really to be to shorten the screen and to make it as easy as possible and as quick as possible. So if we can eliminate some items, we're going to do that. And then last, we continue to integrate across the behavioral health providers and the child welfare staff through cross-training in our learning collaboratives, and as Marilyn mentioned briefly, in the training that's provided through the DCF Training Academy, we've also brought in some providers there. So I'm going to turn things over to Christian.
All right, thanks, Jason. So in the interest of time, I'm just going to give a very brief overview of what we're doing to evaluate Concept Initiative and hit some of the milestones to date. So far, we're just entering our third year of the project. Marilyn described the 5-year grant. It's actually a grant that was divided into a 1-year planning phase and a 4-year implementation phase. And the key activity that, as an evaluation team, we were involved in during the planning year was system-level readiness and capacity assessment to really understand, before we initiated Concept, where the system was in terms of its readiness and capacity to deliver trauma-informed care, and in a manner that's consistent with the definition that Camilla alluded to around understanding the knowledge base and the training education that the system partners had in terms of trauma awareness, as well as knowledge about trauma practices, the implementation of screening and assessment referral procedures, what the state policies were around trauma-informed care, and then other key pieces of trauma readiness and system readiness and capacity included things like collaboration across different child-serving systems. So Jason mentioned that the early work to develop the trauma system in Connecticut focused on behavioral health providers, and what we really wanted to do was understand how child welfare, behavioral health, school, and other parties all collaborated to deliver trauma-informed care. As we've moved into the implementation phase in the second year, we have a complex evaluation process underway that looks at both process, outcome, and costs associated with concept delivery. And we're also interested in the effect of trauma-informed care and this concept initiative on child well-being outcomes as well as system-level change. So we are trying to look at an evaluation that assesses the effects both at the child-family level as well as at the broader system level. Our outcome evaluation includes a focus on some of the workforce development components that Marilyn alluded to, including the 2-day trauma toolkit training for child welfare workers, as well as the learning collaboratives that are underway with both community provider settings and child welfare personnel. Other outcome evaluation components focus on the effects of participation in the evidence-based practices, including trauma-focused CBT, and in future years, the child and family traumatic stress intervention on child and caregiver well-being indicators. And then over the course of the grant, we also want to look at the system level at replicating our readiness and capacity assessment from the planning year to see whether we can document changes across the system in terms of the readiness and capacity as the process is implemented. And over the course of the grant, also to document costs associated with delivery of concept components. So costs to providers in terms of delivering evidence-based practices, costs to the system in terms of workforce development initiatives, and costs in terms of service reimbursement expenses for children who participate in evidence-based practices. We can go to the next slide. Some of the milestones, just to kind of hit some of the highlights from our evaluation to date. During the planning year, mentioned the readiness and capacity survey, we were able to do a mixed method evaluation of readiness and capacity that included system-wide surveys of child welfare supervisors, staff across multiple area offices and also different functions within the department, as well as conducting a series of focus groups with key stakeholders from child welfare, the behavioral health system, caregivers and family members, and other stakeholders to get their perspectives on trauma system readiness before we implemented concept activities. The process highlighted strengths within DCF, including key roles that the training academy plays in providing education and training to DCF staff, as well as some areas of need, such as focusing on greater understanding of cultural competence within the context of trauma exposure, the need to focus on supervisory and staff level training and support around secondary traumatic stress, and the need to develop and enhance greater collaboration across behavioral health, child welfare, and other child-serving systems. A second milestone of the planning year was the ability to obtain different or access to different critical administrative data systems. So if you're undertaking this kind of system-level change, making sure also that you have strong partnerships with the SACWIS developers and other administrative data systems is critical, and that's been a key part of our evaluation work during the planning year and moving into the implementation phase. Within the implementation phase, a key focus of the first year of the implementation phase has been on evaluating the effects of the DCF workforce development efforts through the Child Welfare Trauma Toolkit, and also assessing effects of participation in the TFCBT learning collaboratives for community providers, DCF staff, and family partners. With respect to the toolkit, we have conducted pre, post, and 3-month follow-up surveys with about 450 managers and supervisors who completed the training in the spring. And now we're in the process of replicating that survey methodology with about 1,200 DCF caseworkers and frontline staff who are going through the training, the 2-day training this fall. We have a survey assessment in place that's looking at exposure to training, knowledge of trauma-informed care, and also self-reports of trauma-related screening, assessment, and referral practices. And the pre-post and preliminary follow-up data suggests that participants in this training are showing significant improvements and maintenance in their knowledge and practice over time. So we're excited about that process and constantly feeding back information from that evaluation to DCF and to the stakeholders in the process to help encourage this training. Similarly, for the learning collaborative process, we implemented pre- and post surveys with about 100 individuals across 6 sites who were active participants in that first year of TFCBT learning collaboratives. And that survey parallels our readiness and capacity survey. So we're looking at trauma knowledge, practice, and also collaboration across systems. And again, the preliminary data from that survey process shows significant improvements over the course of involvement in the learning collaboratives and enhanced collaboration between DCF and mental health providers who participate in this in the learning collaboratives. We're also in the process of looking at both clinician reports of delivery of trauma-focused CBT as well as assessment measures of child and caregiver functioning for participants in TFCBT, and starting to look at changes in PTSD symptoms and child behavior as a result of their involvement in TFCBT. So that kind of gives a sense of where we are in the process. It still feels early, but we're, I think, really excited with the kinds of data that we're gathering through this process.
Thank you so much, Christian, and to Marilyn and Jason as well. That's great information, and it just underscores that this is not a one-shot deal, but it's an ongoing endeavor that takes effort from multiple vantage points, but it's all for the benefit of the children and families that we care about and we're serving. So we're going to move now to our final presentation. I'm going to remind you to please use the question and answer feature. We will have question and answer following Audrey Deckinger's presentation. With that, I want to do a very brief introduction. Audrey is the Assistant Commissioner for Child Protective Services at
This is Nancy Archibald at the Center for Healthcare Strategies. I believe that we have lost Ms. Allen.
I'm back.
Oh, you're back. Okay, good. Thank you, Kamala.
And I was talking that the entire time. That's my fault. So I just want to quickly remind folks to please use the Q&A feature, and we'll have questions after Audrey Deckinger's presentation. I said a lot of nice things about the Connecticut presentation that I'll tell them offline. So moving to Audrey's presentation, Audrey Deckinger is the Assistant Commissioner for Child Protective Services at the Texas Department of Family and Protective Services. Previously, she was Senior Policy Analyst at the Texas Health and Human Services Commission in the Office. Sorry, I don't know what's happening to my technology. I was introducing Audrey, and I don't know where you guys lost me. So I'm going to say that she's the Assistant Commissioner for Child Protective Services at the Texas Department of Family and Protective Services. She served as a Senior Policy Analyst at the Texas Health and Human Services Commission and has worked in this field for over 30 years in 3 states. With that, I'm going to turn to Audrey Deckinger for the state of Texas.
Good afternoon. I want to thank the Center for Healthcare Strategies for having us present, and I've already learned a lot from ACF and Connecticut, and we'll be stealing. So if I could go to the next slide. It is really true that every state and every jurisdiction gets to probably the same place in many different ways. For us, what we started with was a real focus on psychotropic medications, and that eventually led us into, well, if we reduce psychotropic medications and we don't want kids to be restrained, we need to do something to fill in that gap, and that eventually led us to our Trauma-Informed Care Initiative. So we don't have a grant from ACF, but we are certainly looking with eagerness at all the states that do so that we can learn from them as well. So the direction that Texas took was child welfare in Texas had been trying since about 2003, actually, to reduce the number of children who are on psychotropic medications. We really saw that we thought that the kids were on too many medications. So we were really battling the doctors, the psychiatrists, the pediatricians to try and figure out a way to not have them prescribe so many medications. And I can tell you that that was not very successful. When a social worker goes up against the medical community and doctors, they don't tend to listen too well to us. So it really took our Medicaid state agency, the Health and Human Services Commission, to partner with us and our other stakeholders, and including pharmacists and pediatric societies and medical societies, to really get to the point where we could safely reduce the number of children who are on psychotropic medications. So in 2005, we released the first psychotropic medication utilization review parameters for children in foster care, and we've released several other updates to those parameters since that time. We have legislators and stakeholders who are also very interested in this, and since 2005, we have had numerous laws passed to improve health care, strengthen the processes related to psychotropic medications such as medical consenters and informed consenters, and then to assure the appropriate use of non-pharmacological interventions. And key among those was trauma-informed care and how to implement that at every level of our system. A big piece to our being able to reduce the number of children on psychotropic meds, strengthen informed consent, and implement a trauma-informed focus in our child welfare work has been our health management organization. We have one HMO for children in foster care, and exclusively for children in foster care here in Texas, and that's called Star Health. We launched that in 2008, and they have been a big player in bringing best practices to the foster children in Texas. It was because of the stakeholders, because of all the work we did on psychotropic medications, because of all the interest in improving the system for children in foster care, that we launched our Trauma-Informed Care Initiative and developed a strategic plan for it. And we have, this is a multidisciplinary committee, and we have done a lot of work on it. Next slide, please. So some of the accomplishments that we have been able to do to date is we have had all of our CPS staff and some of our caregivers trained on trauma-informed care. We have a network of therapists through Star Health that are providing trauma-informed cognitive behavioral therapy, not all of them, but a growing number. And our HMO has been very instrumental in that because they started the overview training for our child welfare staff. They trained over 8,000 people to date before we incorporated it into our basic skills training. We had stakeholders with very diverse views working together and coming to a consensus model. We have engaged the expertise of state and national experts for trauma-informed care and psychotropic med use. In Texas foster care, they serve at all levels on our committee. And we have seen, as a result of this work, a 34% reduction in the use of psychotropic medications since 2004. And you can see on the next slide what that looks like. So you see we hit the high in 2004 on psychotropic med use, and we almost 30%, and now we are just under 20%, so 19.8% in 2012, and I do believe that we went down again in 2013, but we have to get all of our data together. We have also seen decreases in the use of class polypharmacy for children in foster care. Next slide, please. So some of the features that we have in Texas on reducing psychotropic medications and making sure that we have good oversight is that we have trained medical consenters knowledgeable of a child's health needs. They need to be present or participate in the medical appointments of the children, and they have to sign acknowledgement of need to use appropriate non-pharmacological interventions, as well as pharmacological interventions. So we act, of course, as the parent to oversee all of our health care. We have residential operations that must comply with DSPS policies, rules, and licensing requirements, including everything that we must do on psychotropic medications and trauma-informed care. Those provisions are in our residential contracts for both our child placing agencies and any congregate care. Courts, by law, are required to review medical care and ensure appropriate use of both psychotropic meds and non-pharmacological interventions. Attorneys and guardian ad litem must seek the child's input on medical care and must advocate for the child. And in fact, youth 16 or older may serve as their own medical consenter here in Texas by law. And then our HMO, Star Health, oversees the prescribers and provides the psychotropic medication utilization reviews, and I'll refer to those as PMUR in the future. So what Star Health does on the next slide is, again, this is our managed care organization. They are contracted with our state Medicaid agency, and they provide a very rich Medicaid benefit package only to children in foster care. So it is medical, dental, vision, behavioral health, pharmaceutical, and we have an electronic health passport for children in the foster care system. As I said previously, they are absolutely committed to trauma-informed care and have done an enormous amount of trainings across the state for staff, for therapists, for caregivers, for everybody really within the system. They have worked with CASA, they've worked with judges, they have worked with almost every stakeholder group that I can think of within Texas as our partner as we have gone out to do the training. And then, of course, whenever it is thought that a psychotropic medication of a particular child may be outside parameters or may not be appropriate for that child, they provide the PMUR. So Star Health, on the next slide, screens all children for psychotropic med use. They do health screenings when a child enters foster care, anytime they change placement, anytime there is a significant change in the medical condition. And they speak directly to the caregivers to ensure that we know what is happening with the child. There is automated pharmacy claim screening, and because of that, with billing data and pharmacy claims data, they can look at what prescriptions every child is taking and can take action then very quickly if a child looks to be outside of the utilization parameter. Any person, such as the nurse consultant, any of our staff, foster parents, attorneys, CPAs, CASA, judges, can also ask for review of medication on any particular child to see whether it is inside or outside of the parameters. So we conduct PMURs when the health screening indicates the psych meds are outside the parameters, or the pharmacy indicates that the prescriptions are outside the medication, or for any child under 4, 2 or more meds in the same class, and 4 or more meds total for more than 60 days. The court requests these reviews not often, but judges love having access to health information. They have access actually to the health passport. They can look at it for children in their care. They can request PMURs whenever they feel that it's not appropriate. So what happens after the PMUR is triggered? So Star Health then gathers information from the caregiver, from any documentation that's available, and they submit that information to psychiatrists for formal review. The psychiatrist then, not the social worker, outreaches to the prescriber and issues a formal report with a finding of whether or not that's appropriate medication. Star Health also conducts quality of care reviews for prescribers who have persistent prescribing patterns that might be of concern and can require corrective action from the prescribers or even terminate them from the network. So having done all that work on psychotropic meds, we needed to make sure that we then moved into the area of evidence-based practice in our child welfare system. So we launched the Trauma-Informed Care Initiative in 2011 to transition us into a trauma-informed system. We don't expect it to happen fast. We're giving ourselves 5 years. We want to do the same things that Connecticut wants to do: help children heal, decrease reliance on psychotropic meds. We also are looking at secondary trauma for our staff. Our desired future state, what we are hoping to accomplish on the next slide, is really a very similar definition to what you've already heard, and I won't go over that one at this point. So our Trauma-Informed Care Initiative has a steering committee, which is made up of many experts, as well as people from every one of our stakeholder groups, and we have 4 major subgroups on assessment and screening, training, caregiver support, and secondary trauma for our staff. We have a partnership with organizations affiliated with the National Child Traumatic Stress Network, and the training work group developed trauma-informed care training and embedded it into our agency-required basic skills development. We have pre-service and annual training required for all of the people that touch the lives of a child, basically. We have collaboration to strengthen assessments across our child welfare system with the Texas Health and Human Services Commission, the Texas Medicaid Agency, and us currently reviewing all the screenings, assessments, and evaluations for foster care children to ensure that they are all trauma-informed. We have come up with recommended trauma screenings, and you can see them on page 50. And I believe that these are also screenings that are recommended by the Pediatric Association and by the National, okay, help me on this, the National Child Traumatic Stress Network. I always get it wrong. So you see those on page 50. I'm trying to finish this in a timely manner, and I know we're running out of time. So on page 51, we are recommending that these assessments be administered by master's level providers, and that we are recommending optional instruments when indicated, such as the child sexual behavior inventory. We have recommendations for optional instruments when PTSD is recommended, or when PTSD is suspected, and you see those on page 51. So what works well in our system? You know, we have bared our souls on how high the psychotropic med use was in Texas prior to 2004. So there are a lot of things that are currently working well and that have really helped us to reduce psychotropic meds and to move into a new era of trauma-informed care here. One healthcare network statewide, only for children in foster care, has been probably the biggest boon to both the physical and behavioral health of kids in foster care that I can think of. It has been wonderful to partner with them, to have access to the health passport, to streamline and to make more efficient the processes that we have here. Each child has a medical consenter that's knowledgeable about their medical conditions and needs. The requirements and responsibilities are in legislation here in Texas. Star Health was able to provide trauma-informed assessment and a network of healthcare providers with trauma-informed care training. That has been huge. We have had a robust system of oversight and monitoring with shared decision-making across all of our stakeholder groups. We have health passports that show each child's psychotropic medication regime. We have many processes for raising concerns about those regimes. We can outreach to prescribers to enhance their practices. We have forums and stakeholder groups at the state level for all stakeholders to come together to improve systems. And we have brochures and training guides that we have given to all of our staff and to all of our stakeholders. 53, next steps. We're going to continue the Trauma-Informed Care Initiative. We're going to improve assessment and evaluation and screening processes. We'll see what recommendations we are able to adopt and to implement. We are cautiously optimistic we'll be able to implement all of the recommendations from the trauma-informed work groups and from HHSC and DFPS work groups as well. And we will continue efforts to strengthen our informed consent and our medication monitoring. So those are our next steps. On page 54, you see the link to both our psychotropic meds and to our trauma-informed care training. And that is what is happening in Texas on psychotropic meds and trauma-informed care. Thank you.
Thank you, Audrey. That was great, and it was a ton of information, and we certainly appreciate you making your way through that. So we have about a minute left, and so I'm going to take my prerogative to say that if you have submitted a question through the chat feature or the Q&A feature, we are capturing those. We'll send those out to the presenters and get answers, and then we will distribute those to everyone who has registered for today's call. So I apologize we don't have time for a live Q&A. One of the other things that came in was a request for some of the tools and templates that the states mentioned, so we'll reach out to them and see if any of those are appropriate to share, and if they are, we will include those. Next slide, please. So here is our calendar for the remaining webinars in the series. We are doing them every other month, so we look forward to talking to you all again in January, where our focus will be on the sharing of data across systems, particularly for oversight and monitoring of psychotropic medication use. Next slide, please. The next, please complete a brief evaluation that will pop up on your screen at the conclusion of today's webinar. We thank you for your time and your interest, and we look forward to joining with you again in January.
Ladies and gentlemen, this does conclude our conference for today. Thank you for your participation.